with Institutions 2.0. So hearty welcome to all of you. We are having a very prestigious institute from East Zone today in today's session. That is Sikkim Manipal Institute of Medical Sciences from Gangtok, Sikkim. So hearty welcome to all for this enlightening session today. At the outset, I would like to welcome our Honorable President, Dr. Vasant Kalatkar, sir. Thank you for joining in spite of your busy schedule. Welcome President-elect Neelam Mohan ma'am in absentia. Welcome our immediate past President, Dr. Basavaraj sir. And welcome our Honorary Secretary General, respected Dr. Yogesh Parekh sir. Thank you so much for joining in. And welcome all our past and present Vice Presidents who have joined in for today's session. And hearty welcome to our faculty. The Chief Guest sir will be joining in short time. Welcome our Chief Guest, Dr. Sanjeeva Datta sir, Chairperson, Dr. Sudeep Datta sir, and the whole faculty of Sikkim Manipal Institute of Medical Sciences, Dr. Ashish Pradhan, Dr. Jigme, Dr. Doma, and the postgraduates, Dr. Meghna and Dr. Jivesh. And our Chief Advisor, Dr. Jagdish Chinnappa sir, thank you so much for all the support and thank you for being there. And I would now request our Honorary Secretary General sir, Dr. Yogesh Parekh sir, for your opening remarks.
Yeah, thank you, dear Dr. Priya Madam, and warm welcome to the Namaskar and warm welcome to all of our today's program on the 8th episode, Academics with the Institute's program in collaboration with the Sikkim Manipal Institute of Medical Science. And I welcome all of you. I welcome our President, Dr. Vasant Kalatkar, Dr. Neelam Mohan Madam in absentia, our beloved President 2024, Dr. G. Basaji, and Dr. Prashant Sabod, Dr. Shantanu Dev, and whole the team of the Sikkim Manipal Institute. Today's chief guest, Dr. Sanjeeva Dattaji, our Chief Advisor, Dr. Jagdish Sinappa sir, coordinator of this program, Dr. Jayanta Kumar Poddar, my dear friend and Professor Superintendent of the Sikkim Manipal Institute, Dr. Sudeep Dattaji, Dr. Ashish Pradhan, Dr. Jigme Tenjin, Assistant Professor, faculty member, and Dr. Sunim Dona Bhutiaji, Dr. Meghna, and Dr. Jivesh Kumar, PG student of this institute. This institute is a very well-known institute in the Sikkim, and will let us participate in the discussion and insight to learn about our heritage quality of this institute and what is they are having a clinical practice there. For that, we have this is 8th episodes, and let us yet under milestone in our journey to strengthen academic partnership and foster excellence in the pediatric education and the research. As we have almost 50 episodes of the academic of institute in the last year, and we have joined hands with the many premier institute known for its commitment of the medical education, innovation, and academics rigor and commitment, community engagement. So by this, we are having collaborating with the main premier institute, and which are our aim to nurture the future pediatrician, those who are PG students. We have to empower the faculties and promote evidence-based practice that improve the overall child health outcomes in the nation. So I welcome all of you, and let us this May session spark meaningful discussion, dialogue, and what are their new ideas in practice in this institute. So let us together, let us continue to build bridge between the institute and ignites minds for the healthier tomorrow. So thank you very much. Jai Hind, Jai IP. Over to you, Priyaji.
Thank you so much, sir. I would now request respected President, Dr. Vasant Kalatkar, sir, for your opening remarks.
Yeah. Sir. Good afternoon. Am I audible?
Yes, sir. Yes, sir.
Yeah. Good afternoon, all. It's a bring greetings from Indian Academy of Pediatric. That's in a month of festival. Basically, Maharashtra, there is always this is a month of festival, Ganesh and Gauri and everything. Like we are celebrating that Pola Ox Festival today. So I bring greetings from IP to everyone. Respected Dr. Neelam, in her absentia, our President-elect, Dr. Basavaraja, our past President, who is our backbone for me, our Honorable Secretary, Dr. Yogesh Parekh, who is always instrumental in everything and who is really working hard. Then today's my main team behind this program, that academic with institute, Dr. Sanjiva, Dr. Chinappa, Dr. Priya, Dr. Jayanta, and today's main figures who are the behind this program, who made it instrumental, Dr. Sudeep Datta, who will be the chief guest, Dr. Ashish Pradhan, Dr. Dignesh Tenzin, and students Dr. Suldain, Dr. Tehan, and Dr. Jinesh, and all my respected 49,000 pediatrician friends, delegates, and students, and my young buddies. Warm welcome and greetings. Really, this is a program which made a history. Though it's a looking, it's a 8th episode of this year, but it's since last 15 years and getting more and more popularity. That nowadays it's a issue for us to whom we should connect, and to say to whom we should say, we have to say no to present their academics. And this time, especially, thank you to this team, Dr. Sanjiva, Dr. Chinappa, Dr. Priya, Dr. Jayant. Really, they are working hard. I know next time your Dr. Priya's duty will be owned by somebody other due to technical reasons. And there are so many people, they are ready, because Priya had done such a good work that everything is ready, just they have to work hard, just they have to phone. Thank you, Priya. Thank you, Dr. Chinappa. Thank you, Dr. Sanjiva and Jayanta. Really. See this academic with institute, really program, well appreciate why it's not only just one academic, one institute, but we come to know what the academic is there. Otherwise, who knows what is the level of Department of Pediatrics Sikkim Manipal. So many people are confused with the Manipal. People say that the Manipal means that there is a single institute. I am frankly speaking that, but there is a one institute that is in Sikkim, and that to be with a great academic. I really want to congratulate Sikkim department, Sikkim Manipal University, that is the Department of Pediatrics, headed by Dr. Ashish Pradhan, directed by Dr. Sudeep Datta and Dr. Dignesh. So really, we want this. We want to reach the periphery, and we want to expose such good institute that they are in existence. And that was the basic motto. And we know everywhere, whether it's a institute at periphery or institute at metro or central level, like Mumbai, Bombay, Bangalore, but they are working. I know the main thing why I'm happy that this Department of Pediatrics Sikkim Manipal is presenting, because with the limited resources they are working, and that's really India is doing limited resources and so many research, so much things things we are doing, and that to be academic. I really wish a best of luck to this institute and this postgraduate student, Dr. Saldain, Dr. Megha, Dr. Dinesh. I know you are going to the best in pediatric to serve children. I wish you all the best for your future in academic as well as a practice. All the best. And once again, I want to thank you, my colleagues, Dr. Basavaraja, Dr. Yogesh, Dr. Attanu, Dr. Neelam, and all OBEB for giving a good backing since last eight months. They are behind me like solid rock, and definitely it's not all possible without the help of my 49,000. Thank you once again, and let's go best. ऐसा लग रहा है कि ये साल खत्म ना हुए और एकेडमिक इंस्टीट्यूट हुए, और डॉक्टर प्रिया जैसे लोग साथ में मिलते रहे, सो ये कारवां चलते रहे. थैंक यू वंस अगेन. थैंक यू.
Thank you. Thank you. Thank you so much, sir, for your inspirational words. I now request Dr. Basavaraj, sir, our immediate past president, for your remarks, sir.
Yeah, thank you very much, Dr. Priya. So, and respected our national president, Dr. Vasant Kalatkarji, and President-elect Dr. Neelam Mohanji, our Honorable Secretary General, Professor Yogesh Parikh, and all the office bearers. So the academics through the institution is one of the most popular program which has been carried out more than in 1.5 year under the guidance of none other than Dr. Jagdish Chinnappa sir, our chief advisor, and meticulously planning and carried out by Dr. Priya, so our national coordinator for this. And of course, today's program is well supported by Dr. Prashant Sabot, Dr. Santanu Dev, and Sudeep Dattaji, and of course Ashish Pradhan. All of them contributed richly to the our academics over years to the Indian Academy of Pediatrics. And the academics through the institution, this is a program which has been there for everybody, whether you are a postgraduate, whether a teacher, whether a practicing pediatrician. It covers all the three elements. What is the core objective of this? And so Sikkim Institute of Medical Science, Department of Medical Manipal Institute, which has been doing a great work in the eastern part of India, and Department of Pediatrics led by Dr. Ashish Pradhan, who has been doing a great work in the eastern region. I am sure Jayant Poddar, who has been our EB member also, and also in a great teacher, and with their all their support, and Prashant Sabot and Santanu Dev, who are always there. Any work we assign to them, they immediately they will carry out the things. It is a great thing. The best wishes. Looking forward to listening to the work which has been done by Sikkim Institute of Manipal Science so far in the next 2.5 hours. Best
Thank you,
wishes.
Dr. Basavaraja. Priya, let me, sorry, they're disturbing you, your flow. Really, I forgot one name who is taking care of all the eastern region as the vice president, and really he's coordinating, and because of him that this program we could reach up to Department of Pediatrics Sikkim Manipal University. And that name you must be knowing, that Dr. Prashant Sabot, our vice president for East Zone. And really it's a by advice to students. Just we had a conference, joint conference of Indian Academy of Pediatrics along with the MASC. That's at Budapest. That was the international. This was the first try, and we had total 108 delegates from India. Out of that, 70 were faculty, and everybody appreciated all the faculty for their presentation. So we have to go beyond border now, and we should go. That's my basically advice to my all junior this students. So again, thank you, Dr. Sabot, for your efforts. Thank you.
Thank you. Thank you so much, sir. I now request our Chief Advisor, Dr. Jagdish Chinnappa, sir, for your thoughts on Sikkim Manipal Institute of Medical Science. Over to you.
Thank you. Thank you very much, Priya. I'll be very brief because I think we have taken quite some time now to start. Respected President, sir, Secretary, sir, and past President and President-elect Dr. Neelam Mohan and all the others. It gives me great pleasure to continue with this program. This year also we are in the 8th edition. And today we have a very prestigious center from Gangtok, the Sikkim Manipal Institute of Medical Sciences. And though it is, a sister concern of ours and slightly younger than our pediatric department at Manipal Hospital, Bangalore, still it has reached great heights in providing care for the huge population which is there in Sikkim, that too in Gangtok. And thank you very much for agreeing to be here today and present all the care that you take and the advancement that is taking place in this beautiful city of yours. Thank you very much, Priya.
Thank you. Thank you so much, sir. I would now request our Honorary Secretary General, Dr. Yogesh Parikh, sir, to introduce our respected chief guest, Dr. Sanjeeva Datta, sir, who has joined in. Thank you so much, sir. Namaskar and pranams to you for being here on our session on academics with institutions. Over to Yogesh Parikh, sir.
Yeah, thank you, Dr. Priya, madam. Dr. Sanjeeva Datta, sir, having a qualification of MBBS and MD psychiatry, and he is currently affiliation and designation is professor and head of the psychiatry department, come associate dean academics in the Sikkim Manipal Institute of Medical Science, Gangtok. And he has more than 25 years of the teaching experience, very rich experience. And he served as a in the association also in the East Zone of the Indian Psychiatric Society as a past treasurer, past secretary, and the president. He has more than 60 publications in the area of the specifically clinical interest of having a depression and SUD and the creation of the awareness about the mental health in the community. So Sanjeev Datta sir is having a very, very rich academics and the research. He's a very, so welcome to our chief guest, Dr. Sanjeev Datta sir. And over to you, Priyaji.
Thank you, sir. Over to our Chief Guest, sir.
Thank you, sir and madam, for
Sir, unmute, sir, unmute.
Am I audible now?
You can start, sir. I think.
No, Chief Guest, sir, has to
Start.
give his opening remark. Yes, sir, you're unmuted now. You can.
He is unmuted. I think connection is not good.
Yes, am I audible now?
Yeah.
No, you are very faintly audible actually.
Yes.
Something be done? I'll change my.
Good. Okay.
Yes, sir.
I think I'm audible now.
Yes, yes, sir.
Yeah.
Yes, sir.
Welcome.
Echo is there, echo.
Everybody, all the respect.
Please mute all other.
No. Yeah, it is
entities.
already muted, but they are sitting in the same hall. Yeah.
You
Yeah.
Please.
You can
Comments that our
Yes, sir.
is done.
Okay, I think I'm audible now.
Sir, you are audible, but your nearby device is having a that sound. It is having a echo here.
Yogesh sir, he has to go to nearby room.
Yeah, but they are sitting in the same room.
No need.
Possible. Yes.
If they mute.
Unmute, sir. Unmute, sir.
Unmute. Dr. Ashish, unmute yourself only. Yeah.
Yes, I think I'm audible
Yes.
now.
Yes, sir. Yes, sir. Please proceed.
Dr. Ashish, you are audible. The only issue
Good
is.
afternoon, everybody. So, all the respected office bearers of Indian Association of Indian Academy of Pediatrics, all those who have joined online and also those who are offline. So, it's my pleasure to address you all and thank you for inviting me to this program this afternoon. So, just to give a brief about our institute, yes, there is some confusion about the Sikkim Manipal Institute of Medical Sciences. Let me clarify this, that we are under Manipal Academy of Higher Education. Manipal Academy of Higher Education has 4 medical colleges in India. The Kasturiba Medical College in Manipal is very well known. Another medical college in Mangalore. So ours is the 3rd institute located in Sikkim, in the northeastern part of India. And this is the only medical college till date in the state of Sikkim. And the 4th medical college that Manipal has, it is in Tata Manipal Hospital Institute of Medical Sciences, that is in Jamshedpur in the state of Jharkhand. So we started our journey in 2001 when we took the first batch of MBBS students into our fold. But the journey started a little earlier when the government of Sikkim was looking for a partner to start the first medical college of this state. So they approached Manipal Academy of Higher Education, and the then chairman, Dr. Ramdas Pai, entered into a memorandum of understanding to start a university. So this university not only has this medical college, but also has an engineering college, college of physiotherapy, and other colleges as well. So we have, as of now, 150 MBBS intake per year. And we also have a collaboration with the state government, the State General Hospital, that is known as STNM Hospital. And both hospitals together has almost 1,000 beds. And this gives a very strong clinical material for our students. Academy is of highest importance. Academics and pedagogy is of highest importance in this medical college. So we have almost 20 batches have passed out from the portals of this medical college, and we have contributed a lot to the health scenario of Sikkim. Almost 50% of all the medical practitioners that they are here in Sikkim are the students of this medical college. We also have postgraduate program, which we started in the year 2012. The department has a very strong academic credentials along with also in research. I think we have already taken some more time, so I won't make my speech lengthier. Now the postgraduate students will make their presentation, and that will be a testimony to the standard, academic standard of this institute, ably guided by Dr. Sudip Datta and Dr. Ashish Pradhan and their team. So I once again welcome you all, and also thank you very much for giving me this platform this afternoon. I think with these few words, I again welcome you all. Thank you very much.
Thank you. Thank you so much, sir. And we are indeed very happy that you could join our session today. And the whole department will be very happy as you are with them today also. Thank you. Thank you so much, sir. I would like to thank Dr. Prashant Kumar Sabot, sir, for suggesting to have Sikkim Manipal Institute of Medical Sciences. And the response was very good from our HOD, sir. Thank you. Thank you so much for all the support. I would now request our coordinator, our executive board member from Tripura, Dr. Jayant Kumar Poddar, sir, to introduce our chairperson, Dr. Sudip Datta, sir. Hand over to him. Over to you, sir.
Hello, good afternoon, everyone, and namaskar. We are joining in the 8th episodes of Academics with the Medical Institutes. So it's a proud privilege on my part to introduce my friend, Professor Sudip Datta. He is not only a great academician, but also a dynamic pediatrician who has teaching experience over 23 years. Professor Sudip Datta was graduated from Silchar Medical College and subsequently obtained his postgraduate degree from Guwahati Medical College. He worked as a resident registrar in Shishumangal, Kolkata from 2000 to 2002. Since then, he is in Sikkim Manipal Institute of Medical Science. He is a life member of IAP, NNF, ISPAGAN, and IAP Respiratory Chapter and Infectious Disease. He has more than 30 publications, both in national and international journals. His area of interest in pediatric pulmonology and neonatology. He was awarded with Purvanchal Pioneer Shishu Award in 2018 from IAP Institute. I wish all the best for successful conclude this program. Thank you very much. Over to Riyali.
Thank you, sir. Request Dr. Sudip Datta, sir, to take over.
Thank you, madam. And first of all, let me thank Jayant Bhai for his kind words. And I must also thank the Central IIP and particularly my thanks to our dynamic President Khalat Kassar, our past President Basavra sir, Parik sir as well, always has been there for us whenever we needed his help. And also Vice President Prashant Sabot, Dr. Shantanu, our past Vice President, and everyone, like whoever are there in the Central IIP has been very kind and has always seen to it that a place like Sikkim or a place like Gangtok has never been something which has been away from their notice. So I must thank them for really picking us and giving us an opportunity to showcase our case, our hospital, our institute. And I must also today thank my entire department for being here with me. And we will, of course, in the next few minutes get to know more about our department. And without wasting any more time, I think I will introduce my HOD of the department, Dr. Ashish Pradhan. And I will request him to sort of present in brief about our department, and so that we all get to know more about what our department does and what the institute is all about. Thank you.
I'll be sharing my slides.
Yes, sir.
So good afternoon, respected my teachers and seniors of the Indian Academy of Pediatrics Central, and then all the members of the Northeast and the Northern Eastern Zone of IAP, and also my other colleagues and seniors in the Department of Pediatrics in Sikkim Manipal Institute, and also from other parts in the state of Sikkim. Some of the pediatricians who are working in other parts of Sikkim have also joined. So I welcome all of them, and I thank them for taking out their precious time to join this program. So now I'll be starting about my department and my institution. Sikkim Manipal Institute of Medical Science is a constituent medical college of Sikkim Manipal University, which is accredited with grade A+ by NAC in the year 2020. And we have a College of Medical Sciences known as the Sikkim Manipal Institute of Medical Sciences, with the associated teaching hospital of Central Referral Hospital. And we are one of the few models of public-private partnership in medical education. We also share our association with Sir Thutup Namgyal Medical Hospital, which is one of the oldest hospital in the state of Sikkim, which is 1,000 bedded, and Central Referral Hospital is 500 bedded. Now coming to the Department of Pediatrics. So my slides will be focusing on the vision and mission of our department, programs offered by our department, department structure, staff details, faculty achievements, infrastructure and learning resources, teaching learning which occurs in our department, academic activities, extracurricular and curricular, and the future plans of our Department of Pediatrics, Sikkim Manipal Institute of Medical Sciences. So Department of Pediatrics was established in the year 1997 as a clinical department in Central Referral Hospital with 30 general bedded ward and OPD to cater to children less than 15 years of age. After 4 years, that is 2001, we started our medical college with a batch of 100 students. And our department believes in training the students in a friendly environmental training, the students to handle pediatric diseases and health with empathy and compassion. Our vision is to create global leadership in human development, excellence in education, healthcare, and pediatrics, and to develop individuals with excellent professional integrity and technical caliber in the field of pediatrics, and to provide the best possible ethical patient care with compassion and empathy. So the programs offered by us are, we take 150 students of MBBS, undergraduate students, who come through the NIT qualification. And we have 2 sanctioned seats for MD since the year 2011. And there, of course, there also we are recruiting them to the NIT marks, NIT cutoff. And then we also take some PhD research scholars, which is based on the university entrance test, which is based on the UGC guidelines. And also we support certain other programs in our university. That is, we support the Sikkim Manipal College of Physiotherapy in the Bachelor of Physiotherapy and Bachelor of Physiotherapy program. The department structure is such: we have the head of department with the teaching staff of 18, which includes 2 professors, 2 associate professors, 3 assistant professors, 4 senior residents, and 6 junior residents. And we have a non-teaching staff, which includes a child psychologist, office assistant, and an OPD attendant. So we are divided into 3 units for 150 students. We have 3 units. That is Unit 1, that is in the Central Referral Hospital, is headed by me. And Dr. Sudip Datta is another professor, and he's also the medical superintendent of the Central Referral Hospital. And then we have a senior resident, Dr. Sejal Agarwal, will be presenting the research of our department. Then we have 6 junior residents which are registered under us. That is Dr. Mukta Mukhya, Dr. Pruthvi, Dr. Meghna, Dr. Jivesh, Dr. Ashish, and Dr. Patil. The 3rd years are now preparing for the exams, which is due this month of September. Then we have Unit 2 in STNMH Hospital, with Unit 2 being led by Associate Professor Dr. Nidup Doma Bhutia and Assistant Professor Dr. Sumita Tamang and Dr. Sishi Sharma, and Senior Resident Dr. Ruth. And then we have the Unit 3 in STNMH Hospital, which is again headed by Associate Professor Dr. Shultim Doma Bhutia, with Dr. Jigme as Assistant Professor and 2 senior residents, Dr. Amrita Gurung and Dr. Dichen Doma Bhutia. The faculty achievements we have since the year 2015 onwards is, in 2020, I was awarded with SMU Pride Award for Excellence in Teaching by the Sikkim Manipal Institute of Sikkim Manipal University. And in 2008, Dr. Sudip Datta was awarded the Purvanchal Pioneer Award by the East Zone Academy of Pediatrics for his contribution in the field of academics and pediatric in the Eastern Zone. Then Dr. Sudip Datta also held the Executive Board Member Central IAP for Northeast Zone in the year 2018. In 2018, I was certified in Advanced Course in Medical Education by Medical Council of India, which I did in the College of SRM in Chennai. And then I was also became a member of the International Forum of Teachers of the UNESCO Chair in Bioethics in the year 2018. So the infrastructure of a department, we have an OPD, which has a general OPD and a child guidance clinic, a well baby and immunization clinic, thalassemia clinic, a respiratory clinic, and we have an IPD of 10-bedded NICU, 5-bedded PICU, and general wards, of which 25 beds are in Central Referral Hospital and 50 beds in STNMH. And we have a departmental library, which is in our department, that has books of around 200 books of interest in pediatrics and allied subjects. So first, I would like to highlight our neonatal intensive care unit, which was opened in the year 1999, that is 2 years after the opening of the hospital, at level 6 of our Central Referral Hospital. It offers level 2 NIC services to both inborn and outborn neonates. And this was the first level 2 NICU in state of Sikkim and still remains one of the busiest level 2 NICU in Sikkim. And now, of course, in STNMH also, we have a 10-bedded NICU, which is full-fledged. Our NICU caters to ventilation, mechanical ventilation, invasive as well as non-invasive. We have 3 CPAP machines and 1 HFNC machine. We have phototherapy in the form of LED phototherapy, and we have 10 radiant warmers. We cater to preterms, term with problems, and most of the neonatal problems are managed. And we are also backed up by a pediatric surgeon who has joined. She was a student from our institute only. And this is our pediatric ward. Our pediatric ward is 25 bedded in Central Referral Hospital and 50 bedded in STNMH Hospital. We provide care for most pediatric illnesses, and we have a playing area for the pediatric children who are admitted or who come to the pediatric ward. And this is our pediatric OPD, where we have reception, and we have a dedicated breastfeeding room in the pediatric OPD for mother and infants who need to breastfeed during their visit or stay during the OPD visits. And here we can also see that our pediatric OPD highlights the importance of neonatal screening program, which we are doing with the help of the Department of ENT, the our SMIMS, which actively is helping us to screen all newborns who are born in our hospital, as well as outborn neonates with OAE. And also the ophthalmology department also offers visual screening, both for the preterms for retinopathy of maturity, and also the visual screening as advised by the National Advisory Board. We have a child guidance clinic, which is managed by a child psychologist, and she actively manages child problems, developmental as well as behavioral problems, as well as also counsels parents of adolescents who have got some critical issues of adolescence. We have actively running immunization clinic, which we have every Wednesday and Saturday, where we offer immunization services as per the National Immunization Schedule. It is established under the government of Sikkim with the help of UNICEF and WHO, and we are actively monitored by the UNICEF team for maintenance of cold chain, and we also offer non-optional immunization, optional immunization other than the routine immunization as per the National Immunization Schedule. And we have a very dedicated pediatric rehabilitation clinic, which is managed by us and the physiotherapy team. We have a physiotherapist, Dr. Somen Gupta, who is an associate professor in the Department of Physiotherapy, Sikkim Manipal College of Physiotherapy, who is a very well-known pediatric neurotherapist, and he is a doctorate in pediatric neurophysiology. So he actively helps us in managing children with developmental delay, with cerebral palsy, and with motor and global developmental problems. Now coming to our undergraduate teaching, of course, since 2019, we have actively taken role in teaching undergraduate as per the new competency-based medical education, which we impart through experiential learning like bedside clinics. Skill lab classes have been actively involved since 2019 with the development of a skill lab. We have participative learning in the form of interactive didactic lectures, case presentations by students, seminars by students, and we use problem-solving methodologies, especially in our small group teaching, in the form of problem-based cases and case-based teaching. This is one of our interactive lectures, which we are having in our up-to-date, highly technologically feasible classroom. This is one of the classes we are taking in the skill lab, where we are using the skill training of managing children who are sick. So we are demonstrating to the students, and the students then perform in front of us. So we are using the DOP method of teaching clinical skills in the skill lab. This is another skill lab teaching which is occurring in the skill lab, where we are teaching pediatric students, undergraduate students, how to deal pediatric emergency by using stimulations, and teaching them how to work in a team. Other than that, we had some other academic activities for undergraduates, like we had a presentation on ethical considerations in pediatric research for the undergraduate students of 2021 batch last year, where we had presentations, and we also had an undergraduate quiz on ethical consideration in pediatric research. We also had research in neonatology for undergraduate students, which was held with the help of the Student Research Forum, which actively participates in promoting research in undergraduate students, where we had a topic on introduction to research in neonatology, ethics in neonatal research, and we had a presentation of journal club presentation by the undergraduate students. And then we recently had a neonatal resuscitation program, basic neonatal resuscitation program for undergraduate students, which was coordinated by our senior residents and junior residents very effectively. As for the postgraduate teaching, the postgraduate MD course in pediatrics was recognized in the year 2011 with 2 recognized seats. 100% of our postgraduate seats are filled up till date. Till date, we have awarded 18 postgraduate students with MD degree in the first attempt itself. All of them are excelling in the field of pediatrics. 4 of them have done fellowships abroad and are doing very well in their field. Now they have returned back to our country and serving our country well. This is the structured program for postgraduates. We have a journal club every Tuesday where each postgraduate presents a research paper from any journal. Then we have seminar on the first and fourth Friday. Case discussion, formal case discussion is done every Thursday. Of course, every ward rounds, we do a case discussion after we finish the ward rounds. And we also have interdepartmental case or seminar with the help of other departments which are actively involved in teaching undergraduates as well as postgraduates in the form of interdepartmental case or seminar. So this is one of the classes, the postgraduates. We are having a postgraduate presenting, and then we are having an interactive session after the presentation is over. Other than that, we had academic activities since the year 2015 to 25. We had in 2022, we had a basic life support and advanced life support in pediatrics in 2022 September, which was supported by the National Medical Commission and the Sikkim Manipal University. Our resource faculty was Dr. Santanu Dev, who was the coordinator. And then we had Dr. Devjani Gupta, Dr. Kaustav, Dr. Lokesh Tiwari, Dr. Rashna Das Zikrika, Dr. Nandini Sinarai, Dr. Palash Argogai, in which we trained 60 participants on BLS and 30 participants on ALS, after which two participants were chosen for ALS instructor. Then we had a seminar on neurodevelopmental problem on December 2022, which was organized with the help of Shishumangal CDC and RI, which is an institute nearby our state, which manages children with developmental problems, especially autism and dyslexia. And they also introduced us with newer concepts in managing such children. Then we had a workshop on a developmentally supportive care in NICU, which was also supported by the Medical Council of India. Then we had the GEMS course in 2017. Then we also actively involved ourselves with webinar, which was organized with the cooperation of and with the support of the DIAP, that's a Digital Indian Academy of Pediatrics platform. We had the East Zone Clinical Rounds Sikkim, in which two of our postgraduate students and one of our senior residents presented interesting cases we had seen that year, that's in 2021. Then we had also a task module, that is Transport of Sick Kids module, under the guidance of Dr. Urmila Jam and Dr. Romit Saxena from MMC. We had organized this for the state of Sikkim with the help of faculty from both the arts department and from the various Department of Pediatrics of the Northeastern Zone. Then we had recently Dr. Sudip Datta, who participated in a roadmap to achieve optimal control in T2 low asthma. And then we also organized, with the help of Sikkim Manipal University's IT branch, a webinar in which one of our senior resident, Dr. Amrita Patnaik, spoke on influenza. And we had a guest speaker from the Mehta's Hospital, Dr. Muthia, who briefed us on HFNC applications in PICU. Then our social activities, of course, occurs almost every month, in which our postgraduate students and our faculty go to various camps in around the state of Sikkim. They also sometimes go to the state of West Bengal or neighboring state to organize camps in which they either manage and refer children from there for better support and care. And also, we also actively participate with the government of Sikkim. So this is one of the participation in which the Poshan Abhiyan, I participated in Poshan Ki Baat, in which we had a 3 days training for the ICDS workers and health workers on nutrition in infant and young child. So our future plans are, we want to upgrade our intensive care services, especially the pediatric intensive PICU, and to achieve excellence further in academics and to start pediatric subspecialty clinics. So that's all about my department. Thank you.
Thank you, Dr. Ashish. I think we had in brief, a wonderful presentation about what the department is all about and what the department has been doing over the years. Without wasting any more time, I think I'll now request Dr. Chultim Domabhutia, Associate Professor in our department, to give the keynote address.
Good afternoon, everybody. I would like to share our experience with thiamine deficiency in the state of Sikkim. So I work primarily in STNM hospital, which is the government hospital in our state. It's a tertiary level care hospital, and we are associated with SMIMS for undergraduate and postgraduate teaching. So I would like to begin with a very brief case history. This is in March 2023, where we encountered a 6-month-old baby who had come with history of 2 days of poor feeding, not passing stool, altered sensorium, and breathing difficulty for a day. There was no history of fever, cough, abnormal body movements noted by the parents. On direct questioning, they did say that the child had droopy eyes, weak cry, and was moaning. The child was exclusively breastfed, and the maternal diet was predominant polished rice. The cooking method in our community generally is that we tend to wash the rice a lot, and then after cooking also we throw away the cooking water of the rice. And there was history of alcohol intake in the mother, and mother herself had complaints of tingling of bilateral legs. At admission, the child was afebrile, was tachycardic, with palpable pulses and CRT of less than 3 seconds. She was hypopnic with a RR of 25. Anthropometry was normal for age. CNS examination showed that she was responding to pain minimally with pupils bilateral size 3 and non-reacting to light. She was hypotonic, her DTRs were not elicitable, and planters were mute. Her abdomen was distended but soft, and bowel sounds were sluggishly heard. Respiratory and CVS examination, apart from the tachycardia and low RR, were unremarkable. So I'm sharing a video. It's not of great quality, but it just shows the pupillary reaction for this child. So this is at admission when we first encountered the child. So we can see that the child is in altered sensorium, very minimally responsive to pain. And on looking at the pupils were almost non-reactive and or minimally reactive on the left side. After 30 minutes of treatment, this was the pupillary reaction for the child. You can see that it's reacting now nicely. So, and this is the very next day. So 30 minutes, within 30 minutes of some treatment that we provided to the child's pupils started reacting, and within 4 to 6 hours, the sensorium came back. The next morning, the child was shifted out of the PIC to the HDU, and we can observe that the child has some choreatetoid movement of the hands, and she also had some dystonic posturing intermittently. We were able to successfully discharge this child after a week of hospital stay. Initially had problems with feeding, but that was restored. I have picked up this case because when we started our pediatric ICU in STNM in October 2019, straight from 2019 to almost August of 2020, we were struggling with children presenting with acute encephalopathy. We were unable to help them. We were intubating them, but we were losing most of them. We were giving treatment based on acute encephalopathy, maybe infectious etiology or metabolic etiology. While reviewing the literature, we came across thiamine as a possible thiamine deficiency as a possible diagnosis for our children. And after we started treating them in August 2020, we have now literally no mortality from this problem. So this child, between the pupillary reaction that you first saw and the reaction that you saw in the second video, it was just one dose of 100 mg IV thiamine that the child had received. So today's learning objectives would be to describe the crucial role of thiamine in human metabolism, to identify key populations at risk for its deficiency, to recognize the diverse clinical manifestations of deficiency, to understand the diagnostic challenges and current approaches that we have, and to discuss treatment strategies and public health prevention strategies. So thiamine, as we all know, is vitamin B1. It is an essential micronutrient and it is not endogenously produced. Therefore, a regular diet supply is very imperative because it has a very short half-life and limited body stores. A person going without thiamine will become symptomatic within 10 to 15 days, they say. The food sources of thiamine are whole grains, yeasts, meats, legumes, and nuts. Breast milk has a thiamine concentration of 0.21 milligram per liter. Thiamine exists in various forms in the body, but its metabolic active form is thiamine diphosphate or pyrophosphate. The daily requirements vary. Infant will require anything between 0.2 to 0.3 milligram per day, and it goes up. Interesting to note is that women who are pregnant and lactating have higher thiamine requirements, about 1.4 milligram per day. So the pathophysiology of deficiency is that we know that thiamine is an essential cofactor in multiple enzyme complexes which are involved in metabolism of carbohydrates and amino acids. It is involved in the PDH complex, the alpha-ketoglutarate dehydrogenase complex, and branch chain alpha-ketoacid dehydrogenase complex. It is also a cofactor of cytosolic transketolase in the pentose phosphate pathway and a cofactor of 2-hydroxyacyl-CoA lyase, which is a perioxysomal enzyme. The alpha-ketoglutarate dehydrogenase seems to be the most sensitive to thiamine deficiency, and its reduced activity leads to reduced ATP synthesis, oxidative damage, and cell death. What we have to understand is that without thiamine, the body cannot convert food into usable energy. Particularly, this affects the heart and the brain. There is variation in the distribution of thiamine derivatives in the human brain. It is seen that there is compartmentalization of thiamine-dependent enzymes in areas which are specifically involved in cerebral glucose and energy utilization, and hence areas which have higher metabolic requirement and higher thiamine turnover rate, like the basal ganglia, are preferential areas of injury. The transketolase is seen to be responsible for maintaining myelin sheaths, and therefore the neurological manifestations could be addressed due to lack of energy, decreased amount of acetylcholine, and reduction in the nerve impulse transmission. Muscle cells also, those especially with higher energy utilization like the cardiac myocytes, are also involved, and that explains early manifestations like muscle weakness, paresis of GI tract, pulmonary hypertension, and heart failure. So this is a depiction taken from Indian Pediatrics, publication by N.D. Nazir from JNK. So thiamine deficiency will lead to basically cellular energy failure and increased glutamate accumulation, which leads to neurotoxicity. It leads to a mitochondrial dysfunction, which also results in the same problem. Also, increased reactive oxygen species will lead to cell death. On the other hand, it also increases the nitric oxide series, and that also contributes to increased lipid peroxidation and cell death. So basically, we need to understand who is at risk of thiamine deficiency. We need to understand that this is not just a historical disease and still prevalent globally. The interesting thing was that when we were trying to understand what we were dealing with when we were dealing with these patients, we've basically been sending out CSF samples and blood samples to National Institute of Virology for our microbiological diagnosis with NE for the presentation that we were facing. And when the thiamine deficiency theory came up, we thought we should test for thiamine. So we had reached out to National Institute of Nutrition in Hyderabad. There we were in touch with Dr. Mahesh, and who said that it was very interesting because National Institute of Nutrition Hyderabad was apparently built, or it came into being because of thiamine deficiency. And they had a thiamine unit which they were about to close. But this literally the new cases that were reported from several parts of India that kept the lab open, and they agreed to test our samples for thiamine also. The at-risk population at a gist would be infants who are breastfed by thiamine-deficient mothers, pregnant and lactating women, as said earlier, especially pregnant women who have hyperemesis gravidarum, they are at very high risk, and any population with diet which is based on polished white rice, like in Asia, polished wheat flour, which is not fortified like in Middle East, and South Americans and Africans whose diet is based on cassava or sagu. Chronic diseases like alcohol use disease, which thiamine primarily we associated with vernix and encephalopathy. So that in alcohol use disorders we know. Chronic diseases like HIV, AIDS, malaria, medical conditions like post-bariatric surgery, persistent diarrhea, vomiting, socioeconomic factors like poverty, food insecurity, and humanitarian crisis are basically populations who are at high risk. If we look at it in a bit detail, we can have thiamine deficiency when there is a decreased nutrient intake. That can happen in a low socioeconomic status, predominantly rural background, monotonous diets based on milled white cereals, and exclusively breastfed infants, especially fed by mothers who are practicing customary dietary restriction during breastfeeding, are at very high risk of developing infantile thiamine deficiency. There could be delayed introduction of complementary feeding, and even patients on TPN who we forget to supplement with thiamine, they are also at high risk. In populations where the nutrient intake is fine, there could be intake of anti-thiamine factors in diet like tea leaves, betel nut, coffee, fermented raw fish, mycotoxins that can also lead to thiamine deficiency. You could have increased nutrient loss in the form of renal loss, digestive loss, or even people on hemodialysis or CRRTs. There could be increased demand, pregnancy, lactation, we know. Even in critical illnesses, there is an increased demand of thiamine. So if that is not fulfilled, that may lead to an overt deficiency. Refeeding syndrome is very interesting in thiamine. We'll talk about this in a bit. And even small stresses like vaccination can push a child who is in a subclinical thiamine deficiency into an overt clinical thiamine deficiency. You could have impaired absorption due to GI problems or surgeries. And if we understand the prevalence of thiamine deficiency, it is sad, but global prevalence is poorly documented. Various reports suggest that in Southeast Asia, Cambodia specifically, in mothers, they have seen that they were deficient up to 27 to 78%, children 15 to 58%. Africa, in admitted children, they said they were deficient 40% of them. And India, we have good reports from Kashmir, from Hyderabad, and a few northeastern states, including ours. So clinical features could be subclinical when there's a biochemical deficiency, but without symptoms. Clinical deficiency, they have overt disease, obviously. Historically, we know that we've learned, all this while we've just learned that thiamine deficiency could be two things, beriberi and vernix encephalopathy. Beriberi, as we know, are wet or dry. However, thiamine deficiency presents in such a varied manner that now there is an push towards calling these thiamine deficiency disorders a big umbrella which encompasses everything that thiamine deficiency can cause. So infantile beriberi is typically seen in infants breastfed by thiamine deficient mothers. You could have various forms. You can have a cardiac form, which is acute fulminant with a rapid onset. The child may present to you in heart failure, cyanosis with a loud piercing cry, tachycardia, cardiomegaly, and if not treated, it is fatal within 24 hours. You could also have a subtype of this with bad lactic acidosis called as Shoshin beriberi. You could also have an aphonic form where the child presents with weak cry, hoarseness, or no cry due to laryngeal nerve paralysis, and a pseudomeningitic form where signs mimic meningitis. The key message here is infantile beriberi is a medical emergency, and it requires immediate high-dose parental thiamine treatment. Adult beriberi, as we all know, could be dry, wet, depending upon which system is involved. Peripheral nervous system in dry, presenting with peripheral neuropathy, and in wet beriberi, the cardiovascular system presenting as heart failure. However, many patients present with both, and importantly, it is not necessary that only adults are going to go into encephalopathy or only adults are going to have peripheral neuropathy or cardiovascular symptoms. Infants also can have the same. Wernicke-Korsakoff syndrome is the typical thiamine deficiency that we know of. The classic triad is of encephalopathy, ocular signs, and gait ataxia. In pediatric population, the ataxia may not be very prominent. In an acute care setting, if we talk about severe acute malnutrition, when we are starting nutritional resuscitation with rapid commencement of feed, what happens is we are triggering insulin production. This may lead to enhanced protein synthesis, heightened cellular glucose metabolism, and a higher metabolic thiamine utilization and demand. So basically, we are inducing a thiamine deficiency in such a case. And if we are not aware that thiamine can cause a problem, the signs of refeeding syndrome are often overlooked and misinterpreted as sepsis, pneumonia, encephalitis, cardiac failure, and they may even lead to sudden death. Even in cases of ICU or prolonged hospital stay, when children are kept NPO for a long time for various reasons, and in resource-limited settings where we don't have proper TPN for them, these children can also go into thiamine deficiency. We should also suspect thiamine deficiency in children who present with persistent lactic metabolic acidosis or an elevated plasma anion gap, a cardiogenic shock unresponsive to appropriate therapy, and any hypermetabolic state, which is causing an increased thiamine demand, can lead to thiamine deficiency. Possibility should be considered in unexplained severe neurological signs in infants, especially in infants. So diagnostic challenge is that this is a great mimicker. The symptoms can overlap with other conditions like sepsis, other deficiencies, like meningitis, encephalitis, and there is a lack of a single gold standard test. If we do want to test, the recommendation is that since the testing is not standardized and usually it is very difficult to test it, the clinical diagnosis with a high index of suspicion should warrant us to give immediate empirical treatment, and that would be the most practical and effective diagnostic approach. If we do want to test, we can test plasma for thiamine monophosphate, whole blood for thiamine diphosphate, but these do not generally assess the thiamine metabolic function. The indirect or functional assessment would be of an erythrocyte transketolase activity. So basically in this washed erythrocytes, we add thiamine and measure the ETCA value. And if that increases, that shows a thiamine deficiency. So it is a functional assay of biological activity, but it is expensive, time-consuming, and not readily available. So diagnosis could also be supported by neuroimaging. MRI CTs would show bilateral symmetrical hyperintensity signs in mammillary bodies, thalami, periaqueductal areas. Pediatric brain may show lesions in the basal ganglia and frontal lobes more commonly. Indian studies have reported dominant basal ganglia lesions with infrequent involvement of thalami, cortical, brainstem, and mammillary bodies. There are also reports that cranial ultrasound in the initial period could show hypoechoic lesions of the basal ganglia and help us for almost bedside diagnosis of this. So this is from one of our patients. So you can see hypodensities in the bilateral basal ganglia, thalami, and periaqueductal areas. And a MR, which is again showing hyperintensity in the bilateral basal ganglia and thalami. There are also various thiamine-dependent conditions like thiamine-responsive megaloblastic anemia, biotin thiamine-responsive basal ganglia disease, thiamine metabolism dysfunction syndrome 4 and 5, and a subtype of Leigh disease which responds to thiamine. But nevertheless, these children also require thiamine. So treatment, again, I would like to emphasize that we should not delay treatment for confirmatory testing in suspected cases. Severe disease would require parenteral thiamine as first line, since it is safe, rapid, and effective. Mild, moderate, or maintenance doses could be in the form of oral thiamine. Infantile beriberi, we generally give 50 to 100 mg IV IM. If IV access is a problem, IM is also fine, and then this child receive 10 mg daily per roller doses. Importantly, in malnourished patients, it is suggested that we should give thiamine before glucose. The TDD consequences are very high. It has been shown in survivors that there are persistent cognitive and motor deficits. Most severely affected survivors shows marked intellectual disabilities, seizures, motor disabilities, even asymptomatic children. So there was a cohort of children in Israel who presented with thiamine deficiency symptoms because their formula was wrongly formulated with no thiamine in it. So there were a cohort of children who were affected and they were followed up. So they are the survivors. And the cohort which did not show any overt symptoms at that time, later on follow-up of five years plus, they showed delayed language acquisition, persistent language impairments, gross motor delays, poor fine motor delays, and learning disabilities. This is our patient, the same patient who was there, the first case. This is literally from today morning. They have not come for follow-up because they thought the child is fine. So despite the fact that TDT can have problems, we can also have outcomes like this, and we should strive for that. So she's just turned 3. So prevention and public health shortly. Individual level, we should aim for diversified diet, including thiamine-rich foods. Public health level, food fortification seems to be the most sustainable strategy. Southeast Asia's fortify their fish sauce, developed countries fortify their rice wheat. Education in the form of raising awareness in the community regarding cooking habits, regarding alcohol intake and anti-thiamine diet, and increase healthcare provider awareness, especially for lower threshold to administer thiamine. Supplementation should target programs for high-risk group pregnant women in endemic areas. Prevention is far more effective and cheaper than treating. Right now, what we have done is we've started supplementing infants only. So we give vitamin D3 to all newborns. Instead of vitamin D3, we are giving them a multivitamin drop preparation, which has thiamine also. So thiamine deficiency is a persistent global health problem and affects vulnerable population. There's a wide clinical spectrum from infantile heart failure to adult neuropathy and encephalopathy. Diagnosis relies on clinical suspicion in the correct context. Don't wait for lab confirmation to treat. Treatment with parenteral thiamine is safe, effective, and life-saving, and long-term solutions will require public health strategies. Thank you.
Thank you, Dr. Chunti, for raising such an important area. I think this should be an eye-opener for many of us who will be treating children, presenting, and in a situation where, as you have rightly pointed out, a high index of suspicion is required for picking them up. And next we have from our department, Dr. Sejal Agarwal, who is going to give us a brief of the research highlights which have been taken place in the last year or two. And of course, because of time constraints, should be just talking about the last maybe 2 or 3 years what has happened.
Good afternoon, esteemed members. I'm Dr. Sejal Agarwal. I'll be speaking on the research highlights briefly, which is conducted in our department and our institution. Our department and institution have been actively involved in many research activities, wherein we have multiple publications by our faculty members, ICMR projects, and PG research activities. Our PG students have presented their papers and posters at the various zonal and national conferences. And the publications, which is done by our faculty members, it involves a large variety of topics from pediatric neurology, infections, vaccinations, nutrition, which is published in various journals like Indian Pediatrics, Indian Institute of Indian Contemporary Pediatrics. And we also have a chapter on IAP textbook to cite. There are multiple citations which are there by our faculty members from Google Scholar, 76 from Dr. Ashish Pradhan sir's publications, and 279 from Dr. Sudeep Datta sir's presentations. Currently, we are uptaking an ICMR project under the topic surveillance and virological investigation of hand, foot, and mouth disease and acute gastroenteritis in pediatric population of northeastern states of India, which is done in collaboration with the microbiology department. And we also have an institutional project which is under the topic identification of respiratory viruses among SARI patients using real-time PCR and third-generation sequencing for development of molecular respiratory panel, which is uptaken by the Department of Microbiology, Medicine and Pediatrics. And there are two research PhD scholars who are doing research in our department. Their topics being effectiveness of acceptance and commitment therapy-based school counseling program on stress reduction, resilience and coping skills amongst adolescents of Sikkim from Department of Nursing, and the other one being evaluation of the goal-oriented outcomes of neurodevelopment therapy in children with cerebral palsy by Mr. Vinay Kumar, Department of Physiotherapy. Our PG students are having their ongoing research on these topics. A longitudinal study of children admitted with acute febrile illness in a tertiary hospital in Sikkim, a clinical profile of respiratory distress in term neonates in tertiary center in Sikkim, and neonatal peripheral intravenous catheter indwell time and its associated factors, a hospital-based cross-sectional study. The lastly, clinical spectrum of viral respiratory tract infection in children admitted in a tertiary care hospital in Sikkim. Thank you.
Thank you, Sejal. I think you have, in brief, rightly pointed out the research which was taking place and which are going on. And again, now we have the presentations from our postgraduate trainees. I think we'll have Dr. Jivesh Kumar to start with. Is it Meghna? So we have Dr. Meghna Signa Reddy presenting the first case, followed by Dr. Jivesh Kumar. Meghna, you can please take over.
Good afternoon, everyone. My name is Meghna. I am a second year PG student from Department of Pediatrics. So today I'll be doing a case report of a case that was presented in our OPD.
Dr. Meghna, little louder.
Today I'll be presenting a case report about a child who presented in an OPD with amoxicillin-induced rash in Epstein-Barr virus infection. One second. And as we know that Epstein-Barr virus is a causative agent of infectious mononucleosis, which is also called as glandular fever. It's commonly presents with fever, pharyngitis, lymphadenopathy, and fatigue. These symptoms are often mistaken with bacterial pharyngitis and are often mistreated with antibiotics like aminopenicillins that may treat to result in development of maculopruritic rashes in certain patients. So today the case report is about a 6-year-old female child who presented in our OPD with complaints of sore throat, dry cough, runny nose, and fever for 5 days. On day 3 of her illness, she was prescribed with oral amoxicillin, which was administered over 24 hours in suspicion of bacterial pharyngitis. Within 48 hours of starting the amoxicillin, the patient developed a generalized pruritic erythematous maculopapular rash that spread all over her trunk, extremities, and face. This rash was non-blanchable and there was no association of vesicles of Bulle. And the child also developed bilateral cervical lymphadenopathy and continued to have low-grade fever spikes. These are the images of the child. As you can see, maculopapular rashes were present all over the body and extremities, over the face, and even in the palms. On physical examination, the child had temperature of 38.3 degrees Celsius, bilateral cervical lymphadenopathy was present, and maculopapular rashes were present all over the body, and mild hepatomegaly was also noticed on abdominal examination. When recent laboratory investigations, in CBC, the total counts were elevated with lymphocytic predominance, and in LFT, the liver transaminase enzymes were slightly elevated. In suspicion of Epstein-Barr virus, we have sent monospot test, which was positive for heterophil antibodies, and to confirm it, EBV IVC antigen was sent, which IgM was positive. So a diagnosis of infectious mononucleosis was made, and amoxicillin was discontinued, and the child was started on symptomatic treatment with inadequate hydration and antihistaminics. The rash subsided within 2 weeks of stopping the antibiotics. Thank you.
So now Dr. Jivesh, our second year PG, will be presenting another case report.
Good afternoon, everybody, dear teachers, respected professors, my dear seniors, and my colleagues, all of those who have joined us here today in this forum. I, Dr. Jivesh Kumar, second year pediatrics resident of SMIMS, Gangtok. I'm going to today talk about a clinical case presentation very briefly on the topic of mild encephalitis with reversible splenial lesions of the corpus callosum, MERS. We have a patient, an 8-year-old girl, resident of Gangtok, weighing 22 kgs, who presented in the ER of a hospital with symptoms including fever, vomiting, diarrhea, and unusual body movements. The fever was persistent and did not respond to the medication. The vomiting was characterized as non-projectile, non-bilious, and free of blood. The diarrhea was foul-smelling, watery, and also non-bloody. She experienced a generalized tonic-clonic seizure lasting for around 1 to 2 minutes in the morning before admission. The seizure were also followed up by a post-ictal phase lasting for around 5 minutes. There was no repeat seizure after that. Upon examination, she was drowsy yet oriented. The GCS was 15 by 15. She was febrile with temperature of 101 degree Fahrenheit recorded in the ER. Heart rate was 132 beats per minute. The rest of the vitals were stable with SpO2 maintained at room air and CRT less than 3 seconds. She had features of mild dehydration, but rest of the clinical examination, particularly the neurological examination, was normal. Upon getting the laboratory tests, it was noticed that the blood counts indicated neutrophilic leukocytosis. Serum electrolytes showed a mild hyponatremia of 132 millimoles per liter. CRP was elevated. Stool routine microscopy revealed a few pus cells, but no red blood cells or parasites were seen. The stool culture came out positive for Shigella. On doing brain MRI, which was performed on day 2 of the symptoms, we could see in the brain MRI, it was a contrast enhanced brain MRI, which highlighted a focal hyperintense midline lesion in the splenial of the corpus callosum on T2 and flare sequences. It was measuring about 5 into 10 mm. It was indicative of a cytotoxic lesion of the corpus callosum, a defining characteristic seen in MERS. There was no enhancement observed post-contrast, which eliminates the possibility of structural issues such as infarction, hemorrhage, or demyelination. Here we can see an image which shows the corpus callosum, hyperintense signals. The management, she was managed with IV fluids, IV antibiotics, anticonvulsants, and supportive care. The child had showed significant improvement after the start of treatment. There was no recurrence of seizure. The child also became afebrile after the second day of antibiotics. She was sent home, discharged on day 5 of admission on oral antibiotics with a plan including MRI and EEG evaluation on review. The repeat MRI was also done after around 1.5 months, which showed reversal of all the lesions which were initially seen. The diagnosis were formulated as there were GI symptoms with seizure. It was the first episode without any significant past history. MRI showed reversible splenial corpus callosum lesions, and the stool culture was also positive for Shigella. So the final diagnosis was reached. It was mild encephalitis with reversible splenial lesions, that is MERS, which was secondary to Shigella infection. Thank you.
Thank you, Dr. Jivesh. Now I have, I think, very few minutes left for our program to really come to an end. So if there are any questions or any suggestions from members who are actually still very much part of this program, I will request some comments to be really coming from people who are still at
The chat box is all praises with excellent presentations. So for the last case, if Dr. Jivesh can brief on what antibiotics were used and
We used the first line ceftriaxone antibiotic. So and on that the child got improved, ma'am. So we did not go for another line of antibiotic. We didn't add any further antibiotic.
Thank you. Thank you. Regarding the thiamine deficiency, we in fact had presentations from Tirupati Medical College also last year. They had presented cases with pulmonary hypertension and also the neurological manifestations. And there is an article from Jayadeva Institute of Cardiology, Bangalore, around 250 cases of pulmonary hypertension with thiamine deficiency have been documented from there. We had many similar cases here in Andhra Pradesh, Telangana, Karnataka. It's good to know that all the rice, the major rice eating areas are having the thiamine deficiency. So that's what we come to know with that. I would request comments from the seniors. Dr. Srinivasan, sir.
Thank you. The wonderful presentation by each and everyone within time. And the cases were very interesting and the pages have done very well. Well done, Pradhan, Ashish Pradhan. Thanks. Can you hear me?
You, yes, sir. Yes, sir. Yeah. Thank you so much. Shivananda sir was there. If sir is still there, thank you so much, Shivananda sir, for joining. I think he's left. JC sir, your comments, suggestions.
Yeah, thank you very much. I was going to just say what you had mentioned, Priya, about the presentation from Tirupati, which had shown a large number of cases of thiamine deficiency with primarily cardiac pulmonary hypertension. There have been a lot of cases in our area also, where Dr. Vaikuntraju has published quite a few of them from Indira Gandhi Institute of Child Health in Bangalore. So I think it's probably more widespread than is recognized. But the case presentation was just very good. Dr. Bhutia presented the thiamine deficiency case really well with all the details, which was excellent. The other two cases also were very good. Dr. Meghna had presented the Epstein-Barr virus with viral rash following the amoxicillin, and which is well recognized. But again, follow-up is very important there. Dr. Jivesh presented also a very interesting case of MERS with Shigella flexneri infection, which was detected. And I think I must congratulate them for having done a stool culture, because many times this is missed. And finding just a few pus cells in the stool, you would pass this off as a probable viral encephalitis. But getting the etiology of the Shigella in the stool, I think, was a very commendable thing to have been done and picked up. So overall, a wonderful program we had, and congratulations to the staff. Dr. Ashish, I'm really impressed with your extensive ethics involvement, especially in neonatology and pediatrics, and even having a program on ethics. So it's really heartening to see, you being also certified from the UNESCO as one of the ethicists. So thank you very much. It was a very enriching session. Wonderful, wonderful session. Thank you so much.
Thank you, sir. JC sir has done a workshop on bioethics from ICP also in 2023. So he is very fond of bioethics. So Ashish Pradhan sir, thank you so much for mentioning that. Any comments from any other seniors? Jayant sir, any comments from your side?
Thiamine deficiency is mostly common in rice eating and who eat polished rice. The most, even social welfare hostels also, they like only pure white rice. If the rice is some mustard-like thing, just they don't like it and they quarrel with wardens. And we had some deaths also in social welfare hostel in intermediate group in those days, because they used to take to RMPs and they used to administer 5% dextrose for anything. So by the time administration of 5% dextrose, the death is guaranteed. Because again, you are causing more stress and the metabolism. So it was there for the past 25 years also. And it's also seen in fishermen who go away and because they go into sea for 20 to 25 days sometimes, and they are very muscular. But by the time they come and they take rest for 1 week, they start having deficiency and they are admitted in most of the cases. So adults, they present differently, either cardiac or neurological, combined is less. In children, mostly infants are deficient mothers and fully breastfed infant develop this very in infancy.
Yes, sir. Thank you. Thank you for your input, sir. Dr. Prashant Sabut, sir. Yeah, request your comments. I think sir lost the connection. So the whole session was very enriching with a lot of enlightenment on thiamine deficiency, and the postgraduates did a great job by their presentations. Congratulations and thanks to the whole department. Dr. Ashish Pradhan sir, thank you so much for coordinating. And it was really a great session we had today. I would now request our coordinator, Dr. Jayant Poddar, sir, for your vote of thanks. Over to you, sir.
Respected one and all, my dear friends and my dear PG students. It was a really, first of all, I should say, that's a wonderful session. And I first of all thanks the presenter and the faculties who has groomed them for this excellent presentation. It's a really thiamine deficiency prevalence in our state also. We get often a case this time, because thiamine deficiency is suspected and thought of and give the treatment, then it really respond very well. So it was an excellent presentation by all of you, and a big thanks to all of you. And I again thanks the faculties also grooming those all the presenters such a good way, and that's why the wonderful session today we observed. So thanks goes to each and everyone who are present in the sessions, and for them the session was really wonderful and successful today. I like to thanks our President Sir Basant Sir and President elect Nilamji in absentia, and Basavraj Sir, and our Secretary General Jogeshji, and I like to present the chief guest Sanjeeva Datta and chief advisor Jagdish Chinapas, and of course the Pia Madam for your wonderful organization of these sessions. And I thanks Prashantji for his initiative. This program was organized today, and big thanks to him. And I thanks everyone who are present today in this session. And thank you everyone. Thank you very much. Namaskar.
Thank you. Thank you so much, sir. Request all to join for the next session, which will be announced in due course. Thank you all for joining in for today's session. Thank you, and have a great day.
Okay, thank you. Wonderful.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you. Thank you, Priya Madam, for the wonderful coordination.
Oh,
and
thank you,
Jashi
sir.
Yeah.
Yeah.
And whole team of the Sikkim Manipal.
Thank you, sir.
I would like to convey my thanks to the tech team, Saji and Nikita, who are there at the background. Thank you so much for all the support. Thank you. Thank you, sir.
Thank you, ma'am, for coordination.
Thank you. Thank you so much.
Thank you, ma'am.
Thank you. Thank you, sir. Saji, you can wind up the session. Thank you.